Hello everyone, thank you for coming. Welcome to this session of NAUTO's 36th Annual Conference. On your attendee screen, you will be able to enter comments and questions in the audience chat. We hope you will take advantage of this opportunity to engage with our speakers. We recognize and thank our Petabyte sponsor, the California Healthcare Foundation. All conference sponsors have virtual booths available during the conference in the sponsors section. At the booths, you can learn more about the sponsors, review materials, request contact, and collect game tokens. We hope all attendees will take a few minutes to visit each sponsor's booth. Now I will turn the stage over to Norm Thurston, NAUTO's Executive Director, who will start today's session.
Thank you, Marn. It's again this afternoon. I'm pleased to introduce to you Helen Figge from MedicaSoft, and Helen will be today's moderator. Helen, take it away.
Thank you, Norm, and it's very exciting to be here at the 36th Annual NATO Conference. We really want to shout out to everyone here who's attending the show that healthcare at the end of the day is all about data. And without the data, we can't make intelligent, really thought-provoking decisions. I also want to shout out everyone on the NATO board and Norm Thurston and Charles Hawley as well, who's been invaluable to all of us who may be having technical glitches and all of the like. Today, we're going to talk about facilitating the COVID pandemic response with healthcare data. And we have a great set of panelists. Anuj Mehta, who's from Denver Health and Hospital Authority, Sam Hohmann, who is from Vizient, and Brantley Scott, who's from the Utah Department of Health. All of the bios are online, and you can certainly chat with each and every one of us as well as we continue on through this conference. But I really would hope that we get a lot of questions, because at the end of the day, COVID pandemic hit us. It was rather not only physically draining, but emotionally draining for the population. And really looking back, let's see what we can do to improve what happened, what we can see through the data we've collected, and move forward. So with that, I'd like to bring on our first speaker, Anuj Mehta, who will begin the presentation.
I would like to thank the National Association of Health Data Organizations for inviting me to speak today on a critical application of health data during the COVID-19 pandemic. My talk is entitled Identifying High-Risk Populations for COVID-19 Vaccine Distribution, which will be specific to how we used health data in the state of Colorado. I have no financial disclosures or conflicts of interest, and I have not received any payment for my vaccine-related work, although I do receive funding from the NIH for non-COVID-19 related research. The key objectives I'd like to cover today are understanding how claims data supported the development of a vaccine distribution plan in Colorado, assess challenges with how the data needed to be provided at the person versus population level, and also to understand how other data sources were combined with claims data to develop a comprehensive multi-phase vaccination plan. So the problem. Initially, during the beginning of the pandemic, we had no COVID-19 vaccines, but by December 2020, we had the initial emergency use authorizations for both Pfizer and Moderna COVID-19 vaccinations, but they were an extremely limited supply. Thus, it was necessary to consider phased implementations for COVID-19 vaccines. And several considerations were taken. There was views for high risk of exposure, such as healthcare workers, high risk of death, such as individuals living in long-term nursing facilities, moderate to high risk of exposure, such as essential workers in grocery stores or food service industry, and then also moderate to high risk of severe disease, specifically those with high risk conditions such as diabetes, obesity, chronic lung disease, heart failure, etc. And this is the key area that I really want to focus on, the application of health data in terms of developing the plan for Colorado. In Colorado, the GERC, the Governor's Expert Emergency Epidemic Response Committee, convened a group of medical experts, which I chaired, to develop a phased implementation plan for COVID-19 vaccination. And that plan considered the previously stated issues, specifically risk of exposure and risk of death. And very similar to federal guidelines, developed a phased implementation plan that looked at healthcare workers, people living in long-term facilities, essential workers, and then critically important were our higher risk individuals. And so those were individuals with obesity, chronic lung disease, significant heart disease, people with weakened immune systems, et cetera. And the plan was to slowly implement COVID-19 vaccination through the state of Colorado at the county level by moving from one phase to the next. And this was similar to many other states. But early on, we recognized an issue with the phased implementation plan. Specifically, we could imagine allocating vaccines received by the state to individual counties based on their percentage of the population. If a county had 5% of the state's population, they would receive 5% of the weekly allotment. But that led to certain problems. Specifically, Colorado, like many states, has a very dense urban center in the Denver area. So you can imagine that they would receive upwards of 75% of the state's allocation, while Boulder and El Paso, where Colorado Springs were, would receive slightly less, but other areas of the state would receive far less. And this was almost blind to the phased implementation plan, because while population may be one measure, the need, specifically say how many healthcare workers or how many individuals with high risk conditions living in a given community would be different than the overall population. For example, if you did it based on need, it's possible that Boulder, Denver, El Paso, Pueblo, all of these counties would have similar percentages of individuals with high risk conditions, as individuals in Boulder tend to be healthier, so smaller percentage of their population has high risk conditions compared to other places where they may have smaller total populations, but a higher percentage of individuals with diabetes or obesity. And you can imagine that other places would be similar based on the percentage of individuals with high risk conditions. Therefore, we actually started working with CIVIC, the Center for Improving Value in Healthcare, and took advantage of the Colorado All-Payer Claims Database, the COAPCD. This data set is an all-payer claims database that tracks all healthcare encounters, both inpatient, outpatient, pharmaceutical claims in the state of Colorado. It's one of 3 all-payer claims data sets in the entire country. Now, it's insurance-based, meaning it misses uninsured, military individuals, people that seek their care at the Veterans Association, et cetera. Additionally, it's claims-based, meaning people who don't go to see doctors or not seeking medical care would be missed, even if they have a diagnosis of, say, COPD or heart failure. However, it is one of the most comprehensive assessments of healthcare utilization across the state of Colorado and can be refined down to the county level. So the fundamental problem we encountered was and versus or. Specifically, when we started counting claims for diabetes, obesity, and heart failure, you can look at all of the claims for diabetes, plus all of the claims for obesity, plus all of the claims for heart failure. However, you may end up counting the same person more than once. Or you can look at somebody that has any one of the conditions, which is the goal of the phased implementation plan. Specifically, if you count diabetes, obesity, and heart failure, you see those 3 billing codes. Do they represent 3 people, or do they represent 1 person? And one of the strengths of the all-payer claims database is actually with this, as opposed to national estimates of chronic conditions, we were able to identify individual patients, individual people with any one of the high-risk conditions, which is the goal of our phased implementation plan. So the entire process looked where we were able to use the Colorado all-payer claims database to develop estimates of at-risk individuals at the county level. Then we utilized the percentage of insured versus uninsured to estimate the percentage of individuals without health insurance that would have a high-risk condition. And we recognize that uninsured individuals may actually have higher rates of diabetes and obesity based on previous studies. And therefore, we added a 5 to 10% adjustment at the county level based on those. Finally, we combined all the estimates and developed an at-risk total. And these are just fictitious numbers, but this is what it looked like. We took the total population, we estimated the adult population, we looked at what was in the Colorado all-payer claims database, we developed an estimate for the at-risk population, and then we took that percentage and developed an estimate for the uninsured at-risk population, and then added a small percentage. And we got estimates for the entire state population at the county level, which then informed the overall implementation of our phased implementation approach, specifically around phase 2B. However, as I said, this was phase 2B, meaning we had to think about phase 1A, 1B, which were our healthcare workers, our police officers, EMS, and then also individuals living in long-term care agencies. So we combined our data set with other data from our DORA, which is our licensing agency, which licenses nurses and physicians and all other healthcare professionals, with the Colorado Board of Health. We approached the long-term care agency associations to get an estimate at the county level of the number of residents. We had county level population estimates because we knew that there was age criteria for vaccination. And then to estimate essential workers, we utilized the North American Industry Classification System and American Community Survey. And this allowed us to develop county level estimates of each phase throughout the state of Colorado, so we could implement a need-based allocation system for COVID-19 vaccination. And this was an outstanding application of utilizing healthcare data combined with industry data to develop a phased implementation system for COVID-19 vaccination early in the pandemic, when we had very limited COVID-19 vaccines available to the general population. Thank you very much, and I'm open to questions.
That was fantastic. I have one quick question before we go on to the other speaker. How did you determine which high-risk conditions ought to be considered? And what types of codes were assessed in the Apcd? Can you shed some light on that?
Yeah, so thank you so much, everybody, for joining this session. We used the CDC website that listed out high-risk conditions, but that being a physician, I was actually able to look a little bit at my own experiences in the intensive care unit about which patients were experiencing worse outcomes. But we really relied on the CDC, and that then combined it with codes related to ICD-9, ICD-10 billing codes, DRGs for hospitalizations. So it was a big big combination of different types of billing codes for both inpatient and outpatient services.
And it was just, let me follow up on that then. How did the allocation plan work in real time? Can you just give us sort of a sense on that?
Yeah, so you put a lot of work in, and then things actually change in real life. So for phase 1A and phase 1A through 1C, which was our industry-based, so healthcare workers, police officers, and age-based, that actually worked quite well, and we were distributing it based on percentages. By the time we got to phase 2B, there was actually a very large ramp up in vaccine production. So we still allocated it across the state to a certain degree based on percentages, but the vaccine entered this state much faster than we thought it would, which was great. And so it didn't actually have to be as restricted as was described in this original plan.
Wonderful, wonderful. Thank you so much, Anuj. Now let's turn our thoughts to Sam Hohmann from Vizient about the public health opportunity using the ICD-10 codes and outcomes. Sam?
Good afternoon. This is Sam Hohmann. I'm going to talk to you about what I have described as a public health opportunity using newly created ICD-10 PCS procedure codes related to managing COVID-19 patients during the pandemic. CMS found a need to have a way to track use of treatments for COVID patients. So in August of 2020, they implemented the use of codes for Remdesivir, an antiviral medication that was actually approved later by FDA in October, and convalescent plasma, which is a plasma that contains antibodies and for COVID-19 patients, this convalescent plasma comes from survivors of COVID-19. So there's a lot of what, who, why, and how associated with looking at these new technologies through procedure codes created by CMS. Of course, the overwhelming issue here is the pandemic and understanding what's going on. Who needed to know what's going on? Well, public health officials, hospital administrators, clinicians, patients, their families, insurance companies, and so on. Why did they need to know? Well, they need to know what care is being delivered and how often it's being delivered, what's the cost for the purposes of managing burden of care, what kind of capacity planning do they need to do, financial preparedness, and that's just to name a few. And so the mechanism that CMS chose was to add these codes to the lexicon of procedure codes in ICD-10 so that they could be monitored on a go-forward basis. Again, this implementation was until August 2020, and the actual FDA approval wasn't until October. So I'm going to talk about use patterns of these treatments, characteristics of the hospitals and the patients that receive them. The data source is Vizient CDBRM clinical database. It's a hospital administrative discharge data set, like the kinds many of you work with. Not an all-payer data set, it's an institutional payer set. So we've included patients discharged between, actually patients whose these procedures we're looking at occurred between April of 2020 and June of 2021. All cases had these procedures that were of interest, and that's a misnomer. All cases have procedure codes from ICD-10, and some, we'll see the proportions, had these specific ICD codes. These kinds of databases, you well know, have characteristics of patients, including demographics and outcomes, and we can also get some information about characteristics of hospitals that are related to those patients and their care. So the patient characteristics I chose to stratify were age, gender, race, ethnicity, payer, and comorbid conditions. COVID patients were generally older on average. There were more male COVID patients than female patients, and that was actually a flip on the distribution of male-female in the non-COVID population. There were more Black and Hispanic patients who were in the COVID cohort, and Medicare dominated both cohorts, the non-COVID and COVID. However, in the COVID cohort, there was an 11% increase in that domination of cases. The hospitals, there are 737 hospitals that manage these 11.6 million patients. 700 of them were patients who had a diagnosis of COVID, either as a principal diagnosis or secondary, most often principal. 4 strata of hospital sizes. The smallest hospitals accounted for 65% of the hospitals, but they only accounted for 36% of the COVID patients. Largest hospitals, 700 beds or more, were 6.5% of the hospitals, but they accounted for almost 20% of the COVID patients. Similar thing with rural hospitals, they accounted for a quarter of the hospitals, but only 5% of the patients. Teaching hospitals, less than 25% of the hospitals, but cared for about half the COVID patients. And finally, there was also some discrepancy in, well, not discrepancy, disparity in regional management of COVID patients. The Middle Atlantic and West South Central census regions had a relatively higher proportion, each had relatively higher proportions of COVID patients than the others. If we look at mortality across the study period and stratify only by whether the patients had these treatments, either did not or had both or had one or the other, we see trajectories like the one I'm showing here. Mortality peaked rapidly at pandemic surge in the spring of 2020. Non-COVID in-hospital mortality remained relatively constant and at or slightly below 2%. Mortality in non-treated patients and Remdesivir treated patients fell soon after the April surge. So these are COVID patients. And then mortality among convalescent plasma patients, COVID patients, declined, however, remained higher than the remdesivir receiving patients. The blip at the far over at the right is probably an artifact of when the codes took place. There were small ends and long stays associated with those first couple of months of recording data. If we look at now, a different picture is to look at average hospital use rates and stratify by remdesivir urban and remdesivir rural, convalescent urban and rural. We see a pattern not terribly unlike the one we saw with the previous slide for mortality. Well, wait a minute, it's not like it at all. There's an early bump in use of convalescent plasma at rural hospitals, and a less exaggerated bump in urban hospitals. The rural hospitals maintained that high proportion of their patients getting convalescent plasma throughout, and were not far off from 20% of their patients even in June of 2006, while the urban hospitals' use of convalescent plasma trailed off to about 3% by the end of the study period. So there was some doubt as to the efficacy of convalescent plasma, and perhaps some of these urban academic medical centers were the source of some of that trail off. When it came to remdesivir, we saw a leveling by the time FDA approved remdesivir for treating COVID. There was a gradual buildup, which may in our data set have partly resulted from the presence of remdesivir in our line item detail, and so it was always present there. But again, there's this flattening when you get up to October, November. When we stratify by teaching, non-teaching status for which kinds of treatments, this one does look similar to the previous one. We don't have the dramatic step in non-teaching hospitals using convalescent plasma, which we saw before, but those two bottom lines are very similar to the previous ones. We get down to about a 2% convalescent plasma in teaching hospitals by the end of the study period, and perhaps 4 or 5% in non-teaching hospitals. Remdesivir, we actually have a lower usage in teaching hospitals and a higher usage in non-teaching hospitals, somewhere between 40 and 50% for those two, but very much the same pattern. There's a lot of variability in outcomes related to these patients. Length of stay is only 4 days, a median for patients receiving neither treatment. They're presumably less acute patients based on clinical judgment. Patients who get both treatments have a median length of stay of 8 days. Complications when there's neither treatment reach about 4%, same thing for remdesivir only. But patients who get convalescent plasma and both treatments have 5.5 to 6% complication rates. Now, these complications are based on a definition by Vizient for hospitalized patients. So these rates may be relatively low relative to some other things one might look at, like PSIs and HACs. Readmissions is a different matter. When the COVID patients received neither treatment, their return rate was about 11%, remdesivir only about 8.5%. Convalescent plasma was more like the neither treatment, and both treatments was more like remdesivir only. Final comment here is that chronic comorbid conditions, as noted in an earlier table, are about 90 to 95%, and that really doesn't vary across strata, which is quite interesting. I mean, these are sick patients, and they've about, in terms of at least having one chronic comorbid condition, just about everybody has at least one or more. And that's different than the non-COVID patients in the hospital, where the average is about 75%, keeping in mind that the non-COVID patient population includes moms and babies and that sort of thing. So kind of in conclusion here, and some implications about using the data, there's clearly a burden of care associated with caring for hospitalized COVID patients. This data can help can facilitate public health planning, provider capacity forecasting, financial risk insight, and setting of patient expectations. And I'd be glad to talk about all of these things should you be interested in some of them in our further discussions. Thanks.
Sam, did you hear that question?
I did not. I'm sorry.
Are these technologies incorporated into the treatment and care of non-COVID patients as well? Yes, no?
To a much lesser extent. We see single-digit use of convalescent plasma in hospitals over time, and many months none. So it's a limited use of that technology. And remdesivir, although it's an antiviral agent, was used considerably less, remembering that particularly for COVID, it was not a use of remdesivir for COVID until October of 2020. So if it was used for COVID prior to that time, it was an off-label use.
All right. Well, thanks, Sam. I want to get to our next speaker. So we have some questions popping up through the audience, which is fantastic. Our next speaker is Brantley Scott, who works at the Department of Health in Utah. And he's going to really digest and talk about the Apcd claims database to aid the key stakeholders with the vaccine rollout. So, Brantley?
Good afternoon. My name is Brantley Scott, and today I'll be presenting how the Utah Department of Health, and in particular the Office of Healthcare Statistics, aided in the vaccine rollout using our All Payers Claim database. So I've got a few slides here in the beginning that basically, for your information, feel free to review them once the slides are made available. But to jump right into the problem that we were facing, us with many other states, we wanted to understand, what's the population that we have that are at risk from serious illness from COVID-19. And eventually we were looking at these numbers statewide, but eventually we wanted to look at smaller geographic regions. And one note that I want to make is the Utah Department of Health collaborated with several other organizations, and both within our department and without, to help identify the number of people who had this increased risk of COVID-19. And so I'll just talk about our small portion that we did, but some of the other data sources that we used was the Cancer Registry, BRFSS, and the Kidney Registry. But I'll just go on with what we did here at the Office of Healthcare Statistics. And one of the, before we get into that, one of the advantages, or the main advantage I see of using the Apcd for this time of work, is it contains fairly complete medical and pharmacy history for a large proportion of the state. And for the COVID-19, we were looking for specific chronic conditions. And so it made it easy to identify someone who had a chronic condition and was diagnosed a few years ago, but maybe didn't have any other interaction with the healthcare system. We were still able to identify them from the claims history. The other thing that's useful that sort of ties into that is we're able to follow people over time. And so instead of just looking at a snapshot of what people receive services at a given time, we're able to use a look back period to identify these people and follow them throughout time. Some of the disadvantages is it doesn't contain the entire population. And then there's some data lag that's inevitable with the claims getting submitted, adjusted, processed. And so we know we don't have complete data. We know that there is somewhat of a data lag, but luckily for this project, we were really looking for those chronic conditions. And so we didn't need to know, instantaneous data. The other thing that's important to note, and oftentimes people are like, hey, can you do this with Apcd, or can you do that? And we have to remind people sometimes that, the APCD doesn't contain the medical chart records or, any clinical information. It's based on only if this information is presented in the claims data, then we have it. If it's not, then we don't. And so with this, with the action that we've taken, I've broken it into 4 different phases. You can see the first phase here is that we're looking really just at those who are immunocompromised, specifically patients that had gotten transplants at some point. And then phase 2 is when we broke it into different health conditions and by age group. And so we looked at, folks that had been diagnosed with asplenia, some sort of immunocompromised diagnosis, some sort of immunotherapy, liver disease, neurological conditions, or solid organ transplants in phase 2. And each of these phases, there was several different steps within them, but this is just a high-level view of what we did. In phase 3, we looked at these health conditions by local health districts and small health areas. And that was important so we could really pinpoint and identify where the areas of highest need for the vaccine is. And then I've called it phase X, is continued engagement with folks internally at the Department of Health and other external stakeholders to make sure that if there's needs that arise or questions, we're able to respond to those and keep in contact with them going forward. All right, so we were originally given this task back in January of 2021. We had a March 1 deadline for estimating the number of people that could be eligible for the vaccine. And so the first stab at it is we looked at the healthcare facilities database from 2015 to 2019, and we're specifically looking for those who had a diagnosis of a transplant or an MSDRG of a transplant. And we found some of those, but when we looked at them, we're like, well, there's not as many as we expected. And so in February, we looked at the Apcd database and using the same diagnosis and the same sort of procedures, we were able to find roughly 4 times the number of transplants. And part of that is because we have more complete medical history of people who see, a regular physician or a follow-up. We have those professional claims that we're able to identify a distinct count of persons that way. Additionally, I wanted to point out that, we looked only at the 18 to 64 population. One of the drawbacks to our Apcd here in Utah is we don't have good Medicare data, and the Medicare folks in general were already eligible for the vaccine. So that wasn't too big of a bump in the road for us. So here's what the first graph looks like that I created. And this is health condition by local health districts. And you can see it's the age 50 to 64 population. And unsurprisingly, for those who are familiar with Utah, it's really consolidated around, the Wasatch Front and the Salt Lake City County. And that's what you see here in sort of a purplish color. And then you see, the Utah County is this other darker color. And you see Ogden and Davis County has a fair amount of folks as well. But you see those other information, but it's not really clear. One thing I want to point out in particular is this, they call it the Southwestern local health district. And you can see that there is some here, but it's a fairly large health district. And then when we break it down by small health area, it actually really highlights the population there that has the most risk is really centralized around St. George. So when we were working on some vaccination clinics or pop-ups, mobile vaccine teams, we could really point to certain areas that needed it or not. And also in northern Utah, it was somewhat masked in the other map just with the size, but we're really able to highlight in these smaller health areas where the population has the highest risk. And just as my last slide, some of the lessons that I've learned throughout this process, it's really important to save your code and document the process, because as the process went on, there were several different phases and they wanted me to make some adjustments, and having that code readily available and documenting what I did was extremely useful for when additional requests came. One of the other points that I think is really important is we make sure that we advocate what our databases can offer. So don't just sit there passively, but really, when pandemics happen or when there's a need, make sure you say, okay, well, this is what our database can do. Would this be useful? And pitch them a few ideas because they may not know what you can offer. The other important thing is when you do get requests, it's important to clarify what's being asked. I think sometimes people ask us questions that are really vague, and really narrowing in on the specific diagnosis or what they want to know is very helpful, making sure that we produce the data that folks are actually looking for. And then lastly, but not least, it's important to collaborate both internal and external agencies and stakeholders. I think having that collaboration and saying that, hey, well, we have this to offer, but other folks have other things to offer, and really making sure that we use the data that we have and we don't leave any people outside the scope. So that is some of the things that we've done here in Utah, and I'm happy to take any questions you may have. Thank you.
Up to that, how can you actively promote and use your data, feeding off of what you said?
Yeah, so I think it's important that you develop relationships, both internally and externally, that you maintain those relationships and you ask people questions regarding that. So for example, I was just one time, I've recently been working on some geocoding stuff, as you can see, and every now and then we'll sort of have check-ins, be like, hey, have you seen this new data that we have, and push data to them, and they push data to us. So we keep those communication pathways open.
Great. Well, thank you, Brantley. Now I'd like to bring back Anuj and Sam, and I'd like to ask the panel some questions from the audience and to get some reaction to some additional points. So Anuj, the first question really goes to you from Bailey. Did you take into account vaccine history, hesitancy, and how did it affect uptake within the state?
I think that's a great question. Vaccine hesitancy obviously has been a major problem with achieving some of the targets we want for COVID-19 vaccination. And initially, we kind of explored how we can utilize some of our data on hesitancy for other vaccines. So obviously, vaccine hesitancy was a theoretical when we were first developing this, because COVID-19 vaccines weren't actually available. And we realized that it didn't make sense in the phased allocation, because hesitancy, it becomes an issue when you have enough vaccine for people to say no. Early on, it was assumed that we would have very limited vaccine, so the number of people that would want vaccine would exceed the amount of vaccine we had. But in later months, it did become an issue. But at that point, the vaccine was available to the general population, so our data didn't really have to be modified based on those theoretical issues. Also, it's one of those. There have been certain other areas of healthcare where perceived hesitancy or a perceived idea that people would not want a certain intervention actually was flipped around in actual implementation when the demand early on was high and there was very limited supply. Actually, it mitigated the hesitancy, almost like a rare wine. The more expensive or the harder to find, the more you want it. So that's actually what we found early in the pandemic. And then, as we all know, we've seen drop off in vaccination rates kind of across the country. So that's kind of where the hesitancy has started when we have more than abundant vaccine supply.
Anuj, just to follow up, John wanted to ask, did the targeted distribution model move the needle of fully vaccinated in any way?
I don't think it did, and I don't think it was designed to. So the principles by which our phased implementation plan operated on, identifying people high risk of bad disease, monitor high risk of bad disease, and then high risk of exposure and monitor high risk of exposure, was really meant to get certain people vaccinated early on. And by this idea of really full vaccination rates in the 60, 70% range, 50% or below in other states, it only really matters when you have enough supply to vaccinate everybody. So again, the phased implementation plan and how we use the Colorado All Payer Claims database was really focused on when there's not enough vaccine to vaccinate those core people at risk, how can we use health data to guide that planning? And now really we're pushing for now we're really just trying to push to vaccinate anybody who wants it.
Wonderful. Sam, a question is going to be directed to you from Alyssa pertaining to novel treatments. You know, teaching hospitals are generally the early adopters versus the non-teaching generally, but your data showed that there was a higher uptake at non-academic hospitals. Can you give us any thoughts on that?
Sure. I think it's a great question. I would agree with the observation that oftentimes the academic medical centers are the first to adopt new technologies. In this circumstance, in both the comparisons of rural, non-rural, and teaching, non-teaching, rural and non-teaching hospitals do adopt these new technologies, however, not with the magnitude of academic medical centers. Before the fact, I would attribute that to resources for engaging vendors of those technologies in terms of convalescent plasma. I think it was a concept that was embraced by many, and clearly more academic hospitals practitioners embraced convalescent plasma than rural hospitals, although not at the same rate. There was a much bigger uptick. And as the popularity and the efficacy and the science around convalescent plasma didn't support its use, it fell off more rapidly in teaching hospitals than it did in non-teaching hospitals. With regard to remdesivir, the two uses are not terribly far apart. It would seem that with remdesivir, community hospitals are not as discriminating in their patients, or their patients are actually different proportionately than academic medical centers. Perhaps some of those, the clinicians at rural hospitals have determined that their patients are severe enough to warrant use of remdesivir sooner than those at academic medical centers that may have other resources at hand to treat those patients.
And Sam, for these non-teaching entities that adopted the novel treatments, did they require the teaching hospitals to give them some direction? What was the communication or the education, if you will? Can you shed light on any of that?
The quick answer is no, I can't. Shed light on it is what I'm trying to say. Many of these smaller hospitals, rural hospitals, and community hospitals are affiliated with academic medical centers, and I think they benefit from that affiliation. And so one could look at freestanding community and rural hospitals' behavior as compared to affiliated community and rural hospitals. I haven't done that. I don't know the answer to that. That's a very interesting question, though.
Thank you. Brantley, I want to turn our attention a little bit to how do you respond to people that say the Apcd doesn't contain the full population? We saw that the military isn't involved in the data, and we're missing key components of certain populations. Is the Apcd data pool being biased by the lack of the symmetry of the data that they collect? Can you give us a little bit of your thoughts, and how do you think we can fix this?
Yeah, thank you. That's a very good question, and it really depends on the resource question that's getting proposed. You know, when we think about sample sizes in general, you know, the one that comes to mind is there's a lot of like phone sampling or political polling. And they can actually use fairly small samples if it's randomly, you know, selected population. So I think one of the things that I'd like to do is to be able to better understand specifically, you know, when it comes to APCDs, how the healthcare needs of the self-funded versus self-funded plans who maybe aren't submitting data to the APC, is that different than you know, the fully funded or the data that is submitted to the APCD. So for these commercial markets, I've done a little bit of analysis, not a ton, but I found that in general, the healthcare needs of these two populations are very similar. And so I would argue in a lot of cases, again, there's always going to be those corner cases where maybe it doesn't quite fit your model, or the data doesn't fit the question you're trying to answer. But I think by and large, the Apcd does contain a very large sample of the data, and for a lot of research questions, it can really give you maybe not the exact precise number, but it can give you a really good estimate of what the population demand or need is for a certain in a certain research setting or question.
NATO is really priding itself on being able to be the only entity that is agnostic towards data. We are excited that everyone wants to share their data. We're very sensitive to the fact that, of course, it must be secure and private. And I wanted to get your sense of, during this pandemic, we heard a lot of presentations talking about data silos. And many of us have statewide health information exchanges. I know the Delaware Health Information Network won a prize from NATO for innovation, and they collected the data for the state of Delaware. Did any of you have experiences with your state exchanges during this pandemic? And if so, was the data, if you were able to retrieve it, helpful? At the end of the day, if we collect data and it's not relevant or it's not accessible and we can't really understand what it actually means, it's useless to us. So exchanges such as the Delaware Health Information Exchange or Vital in Vermont really have their state under control with data. What are each of your thoughts on your particular entity, if so? Brantley, did you use the Utah Exchange for anything COVID?
Yeah, so I'll speak to that. So the short answer for that, no, we didn't use it for anything COVID, or at least I didn't. One of the things that we're building at the Department of Health is what we call it, Department of Health Master Person Index. And that's something that actually currently right now, we're working to incorporate the Apcd data into this data so we can link it to, for example, birth records or death records that help people know, like, well, what's the birth weight of this an infant, and sort of track some of the health outcomes for those who maybe have a low birth rate if it's not recorded on a claim history. So that's something that we're currently working on, and I'm really excited to work on it, but I personally don't have a ton of experience. And I know Apcd isn't quite yet linked up into all the other data sources that we have at the state.
Anuj, how about you? Did you have any experiences with your state exchange?
No, and I think part of that has to do just with the real-time nature of the data that was needed for COVID. This was something where to make clinical or public health type decisions, you needed up-to-date data. And as has already been mentioned, that a lot of these things have a significant lag, especially if it's based on billing data and things like that. It's not real time. The other issue that we ran into is that some of the exchanges or vital records like birth and death records and things like that, those types of data sets managed, at least in Colorado, by our public health department. A lot of those people that did that type of work were retasked to other areas of the pandemic. So this is one of those things where we've chronically for decades underfunded both local and state public health agencies, and I think we really saw that where we could have used some data patterns to inform deployment of specific resources. We just didn't have the people or people with the knowledge. And I keep on talking about how we utilize for the vaccine planning, but I'm actually a clinician. I spend most of my time in the intensive care unit taking care of patients. Was there yesterday taking care of patients. So it's really this idea of like splitting time, and so there is a wealth of data out there that potentially could be collected in real time to inform decisions that I think has not been leveraged to the best of its ability, and a completely unrelated to unrelated to vaccines, which is where some of my work was, I've been on multiple calls lately, how in terms of crisis standards of care, where we are utilizing, for states that or regions that don't have enough resources to care for everybody, triage protocols and triage scores. And one of the interesting things that when this was first being developed at the beginning of the pandemic, we were utilizing scores like the SOFA score, which take real clinical data. It's utilizing an EMR and things like that. But those underperformed for COVID. And so this idea of how can we link real-time clinical patient-level data to develop predictive algorithms around who's more likely to survive to determine where we can allocate our best resources. And that, is something that I think happens like, Tesla in their Tesla for like auto driving and stuff like that. Or, we have real-time data inputs for so many other industries. And I feel like, healthcare is lagging behind and maybe a direction where we can move in the future. I did want to just comment very briefly, if I have a moment, on Sam's work and the distinction between teaching and non-teaching hospitals. So one of the big confounders in that, obviously, which I think was fantastic work, is the fact that Remdesivir and convalescent plasma were used in multiple clinical trials and research studies. So those are more likely to happen in academic centers. And when a patient either receives Remdesivir or a placebo, or convalescent plasma or a sham, those aren't going to be billed to the patient based on ICD-10 PCS codes. And that may be a little bit of early on where some of that distinction in billing codes may have laid, like in our hospital and most hospitals around us, we were part of some of the early Remdesivir clinical studies. So a lot of our patients received it, but would never have been billed for it or received placebo. So it's just really fascinating to see how all of this data is now coming together to provide a little bit of a retrospective on where we can improve data analytics for the next pandemic, which there will be a next pandemic.
Well, I think it's very interesting because, the pandemic had a lot of physical issues that it precipitated a lot of physical issues, but also there was a lot of emotional ones. And to this day, it still continues on. People are wearing a mask here. They're not wearing a mask there. The intimidation factor, I think, is so overpowering at times. The fear factor really is still out there. And you're right, Anuj, we will most likely have another issue such as this that came on us unexpectedly. And I always say, never in the history of healthcare have we had more technology ever in play at our fingertips, yet the data was still sitting here and there in silos. So we definitely have to work on it where we can get one platform that has FHIR-based solutions and be able to pull it and ask it in real time the question that needs answered. So in our last few minutes, I wanted to get each and everyone's thought, maybe 2 minutes each, of a lesson learned. I know it's a cliche, lessons learned, but this came upon us so quickly and we reacted so feverishly towards it. If we had to do it again, did we put things in place that would make this easier the next time around? So we'll go Anuj, Brantley, Sam.
So, it's interesting. I think we're still living with this. The COVID pandemic has not gone anywhere. And I can speak personally to that based on my experience in the ICU over the last week. It's teeming. So I think that from a data analytics perspective, I do think that things like all payer claims databases can inform strategic planning for deployment of resources. I think vaccines are a great example when you're prioritizing based on certain health type conditions. You have to acknowledge the limitations, right? Like there are certain populations, uninsured, military, that are not going to participate. And also that not everybody gets billed for every condition that they have. So yeah, there are limitations. But again, when we're thinking about how we're going to allocate vaccines through a state, the exact number doesn't matter because in the end, it's a percentage based if you're going to send 10% to one county versus 15% to another county. So I think that there's a lot of opportunity to utilize this type of data in these types of strategic planning in the future. Where I think that we can use a lot more augmentation is load balancing across regions. Something, again, I haven't talked about too much, but there is real-time health data for utilization of specific resources, like hospital beds, ICU beds, nurses, nursing capabilities, respiratory therapy, dialysis. And again, that data is oftentimes siloed. And what happens is that certain hospitals come under strain, especially if they happen to be in an unvaccinated area versus, a neighboring hospital, maybe 150 to 100 miles away, may not be as strained. And so if we are able to pool data, we're able to care for more patients. And in the end, that's the most important thing. So I think that's actually something that moving forward, this idea of real-time collection of resource utilization across a region is really critical for the applications of health data. For health data. Thank you.
Brantley, your thoughts?
Yeah, so my thought, one of the things that, looking about what maybe we could do better in the past or in the future is making sure we have a clear message and we're upfront and sort of, I guess, humble about what we know and what we don't know. We do have lots of data. I think one of the reasons that maybe the pandemic got a little bit emotional is because there was conflicting messages coming from different sources. And even, I'll bring up an example. When it first came out, there was like, oh, masks aren't necessary. And then there were, oh, masks are necessary. And so I think one of the important spots when we're facing anything, of course, is trying to use the data that we have, but also recognize that we don't know everything. We don't, this is, a breaking development and making sure people know that, hey, we're going to provide you the best information that we have as of today, and potentially that could change as new information comes out. So I think that's an important part of responding to this is use the data we have, but also, make sure people know that we don't know everything, and as we learn more, we will provide more information. So that's my thought.
Sam, what are your thoughts as a researcher? And
well, as a researcher, as a data hound, whatever, I was very pleased that the ICD-9 Commission decided to incorporate codes for COVID as of April 1st. It made a big difference. I mean, as Anuj said, and Brantley too, the real-time interactive kind of thing would be very useful to clinicians. Absent that, having those codes that came into being by April 1st, we have a pretty quick turnaround among our member participants in our database, so that by the 15th of May, we had April data to look at. Now, we couldn't build models. I mean, there are a whole lot of limitations on use of data because of adjudication and validation and all sorts of things. And states and data organizations have to cope with those things. Nonetheless, we had some model development already by May and early June to look at whether we were addressing some of these new features of patients, to wit, COVID patients, in a fashion that was appropriate. I mean, so much noise was going on with this whole pandemic that we had a lot of chaos, a lot of places, and that depended on the magnitude of the surge. So some of our New York hospitals were overwhelmed. Their ICUs were overwhelmed. Actually, in the Midwest, there was a lot of planning for to be overwhelmed in ICUs, and the center that was set up at McCormick Place for 3,000 people really never had a sense of more than about 100, and they were low-risk patients. So some of those things emerged fairly quickly, and hopefully we can learn from them as we approach the second surge and the third surge and so on. Vizient had the pleasure of working with many organizations, entire metropolitan areas, on the development of surge response facilities because of our experience in supply chain and in materials management. And I think in Denver, we helped set up a center. There was one in Chicago that was set up, and same thing in Baltimore, as I recall. So from the non-data side, those people were action people in terms of meeting the immediate needs for supplies and space and setting up centers to respond to managing patients. Again, from the data side, there were some curious things, even as I did this preparation of an abstract, that the appropriate use, not the appropriate use, the approved use of remdesivir did not come until October. But remdesivir has been around for a long time. It just had been approved for COVID virus. And there was quite a leveling off once that occurred. I think what we saw before that were off-label uses that were used by clinicians, principally in academic medical centers, because they saw an opportunity to manage something. So, I mean, I'm getting very carried away about what were the lessons learned. I think that there are different responses by different people.
All right. Well, thank you, Sam and Anuj and Brantley on behalf of NATO. And, as a pharmacist, I always say the only universal ingredient in the world that all humans can take, regardless of where we are, is water. So the data is really what we're going to need moving forward. And that's what NATO and all of our organizations are about. And thank you so much, Sam, Anuj, and Brantley, for your time and effort on this episode of this conference. Have a great day, everyone.